adult social care facilities, about reference effects on the unity councils, and a better plan for these older people. Full questions. These are key questions being put together to inform evidence-based scrutiny of the panel 2089. And it's important to appreciate total of the need, problem, it costs, proportion between two unity authorities, Northamptonshire County Council, Borough Council, how will better working partnerships with NHS providers, charities, care homes work, how will funding be apportionate, and then the private PFI contract sure companies, especially the safeguarding principles and adults. It's interesting. That is the question. So, yeah, that's how I'll be just do the descriptions and just pop it in there to have a look at what's going on. Question 8. Care and housing provision with housing qualities, housing impacts on physical and mental well-being. It's interesting. Housing options involved to meet new emerging demand, which is true. Set to code independent living, what does that look like? So it's interesting to hear what they have to say. So here we go, people with long case studies, housing for studies, housing providers, property, working in partnership, helpful. Support independent living with older people and those with complex life terms.
Sorry to ask you again. Just double checking, is item 8 you were speaking, wasn't it?
No, it was the adult health.
Oh, item 6A then.
Oh, 6A.
Yeah. Okay, 6-1. Yeah, 6. Yeah, okay.
I've still got it on the internet. I've got it more complicated. 6A I'm going to speak on. I've got the agenda on there. So housing options is a key point of independent living. Adult health, social care, so people are not alone and isolated. And people living in prison, hospital, so it's good they're looking at this. So they're looking at the questions to try and make sure and any examples of new ways of working on the website, interesting to look into. Then we've got Northampton Hospital Discharge Scheme, so meant to work together. So then you've got South London Support Living Schemes with learning disability people, which sounds interesting. And then you've got prevention area, agenda, what's being delivered and the plans to work in the future. Funds moved, political people don't like me being a disabled woman in the wheelchair. The wider place system planning.
Okay, so we'll make stuff. We have we have one public address, one public speaker on item 16. So we invite you to speak at that when that comes up. Thank you very much. We'll move into the minutes, because I think we had a chance to look at the minutes for the last meeting. Are you happy to repeat those? Thank you. We have unfortunately still got no co-optees to the review. There were some options that were being explored, but we don't have any town council co-optees to review. So I think if it's all right with the panel, we'll again express our kind of concern about that and note that in the minutes that we are again, as with last time, very disappointed not to have that involvement. for me, it raises some concerns about partnership working going forward, and in the light of unitary, I think this relationship and communication between the borough and the county over issues like this really needs to be improved, and we need to note that we've not had any ongoing parties, because I think that's a concern for me. So we'll move on to witness evidence, and for 6A we have had apologies on the cabinet needs for adult social care from the county council. So we'll move on to 6B, which is the executive director. So we've got the Anna and her, but if I can ask you, sorry, probably just one thing first. So, Laura, if you'd like to come forward and speak to the panel.
Thank you.
Thank you very much. You've got 3 minutes to address the panel.
Thank you. Thank you. Thank you.
Okay, so if you press that button.
Thank you. Thank you very much. Good afternoon, members of the panel and others present. I'm unfortunately experienced the cutbacks, and I'm glad to see we've got colleagues here from Northamptonshire Adult Social Services, and I'm very impressed with what I'm reading, that what you're trying to look into to move forward. Things are not working. I'm surprised there's no one else similar to myself, probably here, and I didn't know this meeting was happening until the other day. While going through the complaints procedure and having the months or weeks of the Care Act assessment procedures, the effect of the cutbacks in reality on the ground level, I don't know, you might hear of this on site visits, not just me personally, but I'm seeing this on disabled people against cuts on their national social media and all over. I have to be off my sick bed to come here today, and it's frustrating for the staff because there's a lot of effects by the workloads. I experience that. Applying staff try and help me. They've left their job, they're fed up, and I'm without a social worker. So if you don't have a social worker, that affects on the continuing offer of initial stage is the short-term benefit in South, what team one lives in. It is like a postcode lottery, because unless you, for example, if you have complex, this is why I saw one of your questions was quite interesting to see what the answers might be or what you might investigate. The problem is when you have complex disabilities, mental health or long-term physical disabilities, and there's a funding issue. And what I'd like to see how it's going to work with the 2 Unity Council proposals coming in, and especially the housing. So I'm in a situation where I have 1 year and 4 months and no wet room repair. So it affects the health, and then you've got the disabled individuals are looked upon on the safeguarding aspect on section 42 of the Care Act, class 14. So I've had to be my own lawyer really to understand my rights, and the cutbacks in statutory advice services are stretched. So unless you can get out to their services, there's no help. They do mean their best. So what I'd like to express my serious concerns is that there are a lot of people sitting through the gaps now, and the Care Act assessment process put on hold. Thank you. I would like to have that seen reinstated without the effect of trying to get replacement of a social worker to move forward to have a life. It's all about what people can do, disabled people can do, and their limitations, and that's all I'm trying to do. But I'm stuck in thousands of people, perhaps, I presume. I can't speak for them, just me, but this is what's happening. And although we've got a new building being built, and although we're looking at the process, it's not happening quick enough, unfortunately, and people's lives are seriously affected, and it adds on to other aspects on the NHS pressures. You end up in hospital, and then it just adds on. So I'd like to see a proactive with all the representatives and members of our certain services here to aid, not just look at us as a funding nightmare issue, but actually looking at what realities are and working together. Because I do not like making complaints procedure. I don't like going to the Director of Adult Care or Capernenshaw. In that process, it takes energy and time that I could better make use of. Thank you very much. Thank you.
Are there any questions? Any members?
Thank you very much for coming tonight. How long have you had to use the services?
2014, unfortunately, I'd had to cut the services by certain, I can't go into certain things because these people aren't here to speak for themselves. But when I used the complaint procedure then, and certain things happened to me in a horrific nature, the old system, which used to be known as the Youngest Ever Adults Team, kept reprinting old care plans that didn't meet my needs and blocked me from the self-direct support process. So all these years on, my private friends are just that, unpaid care for, and they do their best to help me. This is why when I ended up having a stroke and a mini heart attack last year, and if it wasn't for me talking to my daughter at the time, streaming on Facebook, I wouldn't be here today. And had the police kick in my door, they rushed me to the ambulance, that cost the extra onto the NHS, and that's when I contact First Point of Access, the County Council, to see what now could be offered. So now can move on with the, say, eventually, I didn't know what this Care Act was about at the time. I didn't know what was what, and I had to learn pretty quick. So unfortunately, I had both things going on. I had the major housing disrepair, the wet room, that's still not happening. And until you have such and such happened first, you can't access, yes. And until the front door, so to speak, like with the steps department, they can, when I'm looking at the care needs at 2012, can pause it if they deem that you might benefit from such and such a service.
Do you get a personal independence payment, or how are your benefits?
This is all affected as well, because if there's a cutback in access to services or delay, like the social worker was, she was so kind until she left the job on the 31st of 10th this year. She was with the Care Act Africa, which really appreciated their help immensely, because my other unseen disabilities, they were going to sit in on an OT assessment this week. I've just had to post a rejection of the offer and put it on hold. I cannot cope with two strangers in my home like that, I don't like, because my doctors and so forth, I've had to ring them twice or update what's going on. Yeah. So when I ring up this number, it's frustrating for everybody else in their departments, because there's so many people like me. And when I rang up and my old friends have tried, I'm being washed out in buckets of water in unsafe conditions. And this is I don't speak about it because we've got homeless people. So I just try and move on. So when I've tried to word it in such a way, without trying to not be disrespectful, I've contacted my councillors' representatives about the situation. It's frustrating, I don't want to. And because other people are worse off, that's how I look at it. But unfortunately, where my friends are struggling on the extra task I now have because of what happened last year, I have now the door fits, but I haven't been able to have a shower for 1 year, 4 months. And that's human rights element included in that. It's not necessarily the fault of frontline staff, they didn't mean their well, it's the pressures on finance. Absolutely. And unfortunately, until they are trying their best, it's just not the staff there. So until I get an offer of a social worker, and other people like me are stuck without carrying on with that assessment, without carrying on with the moving on to like the independent living housing model, and without carrying on with the OT assessment.
It sounds as if you're caught in a really difficult...
Yes, that's a lot of people.
I hope things will solve very quickly, and thank you again.
Thank you, Councillor. Thank you, Councillor.
Thank you very much.
Thank you.
I'd like to call for down. Thank you.
I'm just staying for this lady's speech and then I'm going, and yes, I will.
had, and I said to Tracy, was raised a whole series of questions here, which are hard from my point of view to be clear exactly what you're trying to get at, because it can mean many, many things. So I provided some general practical information, which I can refer to, but I wanted members to go through them as specific presentations. So I'm not sure it might be beneficial if it says general information, and then refer out to information to the question great, and then hopefully that leads us to other places. I can either provide additional information or refer you to the presentation. So the first question that you'd asked in them is about the totality of the problem and how and its cost, and then how that would be apportioned in the two new unitary authorities. So I have provided in one of the packs a summary of our budget, and I can provide more information. So the reality of our budget is we spend £244 million a year, and that's divided up into a number of things. In the main care, so of that 244 million, 190 million of it gets spent directly on care for people. So that means contracts and providers that we use, also some block contracts, so in-house contracts or wider sort of groups of contracts. And then on top of that, we have staffing, as you would expect, and then other sorts of smaller amounts of money. But the large majority of it is spent on care. And our care is defined or set out in types of care. So you'll see, if probably worth looking at one of the slides in terms of the budget, you'll see obvious set of slides, that was the care briefing, 6th of November, slide 17, sets out the budget for you. So you can see that within that budget, what you've then got is a set of care spend that is divided across older people, people with learning disabilities, people with physical disability, mental health, other personal care needs, costs, equipment, etc. So our budgets are split like that, and underneath that, obviously, then we have customers. So in terms of how you split it in the unitary, well, all of our customers obviously still live in areas. I think it's still yet to be decided, and it's an ongoing debate, discussion with government and with all the chief executives of all the district and boroughs about whether it makes sense to divide it and for other services, locally delivered and social workers, it probably makes sense to have them split into the locality areas, but there will usually be some things that we do at a very high level. So quality and safeguarding might be one, another one might be the teams that we have that manage specialist assessment, mental health assessments, and the more small functions we have, and then commissioning itself, which may work better at a community level because you get economies of scale. So there's a lot still to be decided. So I can't sit here today and say how will it be split. If I was asked to split everything by postcode, we could do it. It would probably get a lot more expensive and ineffective to do it. So it is an ongoing conversation around how we design services. But what we are doing in the service already, in preparation, is starting to report everything by area so that we can actually see a north version and a west version, if that's what the government decides to do, of what the services look like. So unfortunately, it's not a question I can answer at this point. In terms of how we're working with partners and the NHS and charities and private sector, how will that develop? So Ken's role is vital in this, So Ken's role is not just about managing contractors who provide home care or residential care and all those sorts of things, but he also has an active role in the voluntary sector and works with them in terms of solutions for our services, because you don't necessarily need formal care for everything. The voluntary sector, community services can provide really, really good support and care. So he regularly talks to those. I'm sure he can give some examples in a minute of the sorts of conversation that he's having. And then we're also obviously part of the wider sustainability transformation plan for the county, which is across all providers, health providers, voluntary sector providers, GPs, all the different providers. So we're working with them on various programs and projects at the moment, and this is about joint delivery, because, for example, we all know and we hear in the press about hospital pressures, but the hospital pressures become my pressures, or my pressures become the hospital pressures. It's one system with a set of people who are going through it, receiving care that we have to manage. So we're working with them all the time. I meet with all the health partners, which is the operating officers, and then the STP board and the health and wellbeing board. We also need voluntary sector, district and borough leads, all sorts of people. So we are connected in everything we're doing, and quite rightly so, because the solutions are coming out for all of us. And we have lots of opportunities to do that. Do you want to just touch maybe on
Certainly. So I can give you a couple of examples of things we do with both the independent sector and the voluntary sector. I meet with the Care Association on a monthly basis, and we sit there and discuss a whole range of issues from their perspective. As you can well imagine, one of the things they'd like to discuss all the time is fees, but they also like to talk about the improvement in their workforce. So one of the biggest challenges we face in the authority is the challenge of recruiting and retaining care staff. And quite frankly, it's not an easy job. So we're looking at having joint recruitment strategies. We're looking at working with them to have promote the sector as a viable career alternative, making sure people have got the right training, the right competencies. In terms of the voluntary sector, we meet on a very regular basis with the voluntary science team. So one of the things that occurs to all of us is the importance of getting through that hospital. People don't want to pay for taxis, they don't want to run their car home for a cost of care, they don't want to huge trust. So we're trying to set up a relationship with the private schools who regularly take people for what they say to us is comes back into us. I think one of the other things, certainly organisations like Age UK, is that frankly a lot of people don't want to be local to social care. Trusted brand, like the Alzheimer's Society, to talk about issues that are concerning them. And in a lot of cases, they're more willing and capable of paying for that care themselves. One of the things that, if we're going to have a sustainable way forward, we do need to put some effective prevention measures in place. So you will find that there are a whole range of 70-year-olds looking after 50-year-olds with a learning disability. They have no contact with adult social care, and quite frankly, they don't want to, until the point at which they're brought into crisis. So what I'm not suggesting is that we're going to solve the world's problems, but if we can put in preventative services that give them that little bit of help, a little bit of support to allow them to remain independent, place of their choice, they have the backdrop of social care assistance if and when they need it. That's one of the things that I think is going to help not just the local authority, but also people that might require services at some point in the future.
So question 3, how will funding be apportioned? I assume you mean by that in terms of our total budget that we get. I mean, ultimately, central government provides funding, the grant funding on a needs formula, so based on the population. But as I said earlier on, ultimately, all of our budgets are, and most of our spend is made up of individual care packages. So in effect, the care package and the spend, if you like, goes with the person, with the services. And if we do end up dividing everything by the 2 unitaries, then that will get apportioned in that way. We're not expecting the government to do anything different in terms of its direction at the moment, but there is a natural way, as I said, of splitting people almost by postcode to the areas when it comes to it. In terms of the Shaw PFI contract, I can only say some things here, because it's obviously a commercial situation, but I know a very public one. So the things to note about the Shaw PFI contract, there's 4 centres in the PFI contract. The contract was signed in 2003, right at the very beginning of PFI. It is a really challenging contract, and it's a contract where various experts, including the Treasury and Department of Health, have been quite clear that it's quite an old-fashioned contract in the sense that it many rights or many remedies in terms of when things don't go well. So it's been a long-standing issue to try and work with Shaw to get more uptake in terms of people. That said, it's not Shaw's fault to design the contract at a time when more people were going into homes and more people were going into centres. So when we signed the contract, the average person who would go into one of these centres for rehabilitation now today would go home and wouldn't go into one of these. So we've got to change basically in needs of the population that the contract doesn't recognise. So I have some sympathy with Shaw in the sense that we're now talking about more complex people going in than we originally did. That said, the contract doesn't work well for us in terms of our ability to make sure occupancy is up where it needs to be. So we are doing three things at the moment. One is we introduce new contract management to more robustly challenge when they refuse to take people or when we don't think that they're actually complying with the contract. Secondly, we're in discussions about the long-term use of contracts and how it might be changed to accommodate the fact that needs have changed. And the third one is we're working with Departments of Health and Treasury at the moment in a sort of three-way facilitated conversation to find solutions to take us to that place and get a new contract in place. So those are kind of the three prongs of attacking like for trying to improve that contract.
I was going to take into that. Whilst it might seem like quite an adversarial relationship, we're also being quite supportive in terms of offering their staff additional training, benchmarking their services against similar care homes across Northamptonshire and saying, look, this is the level of acuity that 10 care homes take. Let's just explore why you're not willing and or able, and then try and work with you to make sure your staff have the competence, the confidence, and the management skills and support to make sure you can take people with high levels of acuity.
Yeah, that's okay. Yeah.
Thank you. I'm interested to know why people who originally might have gone into one of the short care homes are now going home. People haven't changed much in the last sort of 15 years, but perhaps the support levels that people were expecting has changed. So is this an indication that because there's been a huge reduction in funding in social care in terms of the number of carers coming in to meet people, coming into care for people, maybe I'm coming from it from a different angle. People now, their expectations are far different. So where before families would expect their loved ones to go into a short care home, they're now looking after them or organising care themselves.
No, it's not anything to do with the funding. We spend 50 million more today than we do back in 2013 or 14 to spend it on up. It's actually because over the years, best practice has changed. So more people went into cottage hospitals, more people went into these sorts of centres, and a lot more people went into residential nursing care. And what's emerged over the years is actually you shorten people's life quite a lot if you do that sort of thing. People, it's a horrible word, but it's something that hospitals use, decompensate, so they become less independent the more they're in those sorts of places, when actually if they're with a support at home, they can stay where they want to stay. And also, the things that we can do in terms of equipment and therapy and everything has changed too. So now, best practice is completely the other way around, is you should be looking to maintain people in their homes for as long as possible, without sounding sort of too, making it sound too harsh. I mean, the average person in this county now goes into care about age 89, which is quite high. And the average person in the care home will only live for 18 months. So if you don't want people to be in that situation, as to say, and start to maybe go down and become less independent, then you would take them home. So it's more a change in practice and understanding about outcomes than anything else.
Thank you. Thank you. I'm going back to Shaw again because it's exorbitantly expensive. You've got empty beds there. And people are, I can understand why we can't buy ourselves out of a contract, get out of it altogether. If Shaw won't cooperate, they won't even be interviewed, when it comes to reporting. To me, it was a horrendous contract to be set up in the first place. But the money it costs, it is that money is so better used by looking after people in their own homes, or when actually people do need nursing care in a home. Why haven't the county council been more active at getting us out of this contract?
So for certainly as long as I've been at the council, we've been actively looking at it, and I've been there 2 years and trying to manage it. We've just been through an exercise with the Department of Health and the Treasury about potentially buying them out, but we had conversations with Shaw about that. The reality of, without getting too technical, the accounting treatment of this is that whatever we spent, even though we have the capital to buy them out, would end up on the public balance sheet. And because of the way these contracts work, it's not the value that we buy them out at, it's a lot more because you buy them out for their future years of profit too. So ultimately, the government departments have said it's not good value for money to buy them out, and therefore they won't accept us doing that, so we have to find alternative means.
But they haven't suggested any other alternative means.
Yeah, so they're active. I met them on Monday with Shaw. So they will do a 2-week moment, a monitoring period where the Department of Health and Treasury are involved in what happens over a 3-month period and what refusals we get, and then how we improve that. And then they're also supporting us in a longer term variation. Our current view in the council we've shared with Shaw is that we need to move into longer term use, because as I just said, we don't need the short term rehabilitation places in the way we used to. What we actually need now is more complex nursing care and dementia care, and that's what we're trying to do.
I've got Councillor Oldham and then Councillor Hatch.
Thank you, Madam Chairman. Pretty simple question, but pretty loaded actually. What's the cost of somebody going into a care home? What's the cost for that? What financial situation have they got to be in before they can go into a care home? And if they stay in their own home, what's the adult care that's needed to look after them, should they qualify? What's the cost of that compared like for like? Because what I'm thinking of, we've got a massive problem with adult care, nobody's going to ignore that, we know that. And I just wonder, this is where the loaded and unfair question might be. How many adult care patients have we got that's having to be looked at by adult care staff, and how many care staff have we got in relation to the patients? Because that, I know it's loaded, but I'm just wondering if we have the facilities to look after people sufficiently in the right way.
Okay, so that's a whole different range of questions.
Okay.
So-
Me finished, aren't
Yeah, so let's start with the point at which people pay for something, or what they pay is entirely set by legislation. So the Care Act says that somebody who has less than £23,500 potentially will have social care paid towards their care.
So 23,000 a book.
Yeah, including savings. Okay, if you are going to a residential home, it's possible to take into account the value of your home in terms of it providing for future cover for it. If you are staying at home and getting home care, you don't take the value of the home into account. So it is it's not sort of easy to navigate. Now, the costs of the care to the person will depend on their needs. So as I said, we do a financial assessment for everybody as well as an assessment of their needs. So if they're classed as entirely needing social care funding, we pay the full cost of it. Obviously, if they've got to contribute, that's set according to their means and the different contributions.
Just means tested.
Yes, means tested, yeah. If you look at the slide pack I was just talking about, page 16, so the one over from the budget, you see there's a wide range of costs that you get for different types of care. Top table being people who are over 65, the bottom table being people who are younger adults under 65 years old. So what you can see there is you can have somebody with very complex needs and a very high cost package at home, and also support them at home. As I said, but in that situation, you don't take into account the cost of their home. And equally, you'll have some very, very low costs. And that's true of all the different types of care. So the care provided will depend on what the person needs. And it might be specialist, so in residential care, for example, the very lowest level of residential care, so you need to go into care homes, you need 24-hour care, but it's very low level social care type need, might be as low as £420 a week, but could be as high as £800 a week if it's more complex. It does depend on what sort of care you need. It goes into nursing, there are more expensive, very high expensive, in the county, £900 a week, which is a national issue. So it's kind of not an easy question to answer because it depends on the person's need and then provision. So in terms of how provision, myself, I've got just under 1,000 staff, and some frontline services we run ourselves, so 5 care homes, day centre services, home care services. But the staff across the county will be huge because we have 450 providers-ish, something like that. So a huge amount of providers, and 250 of those are care homes. So obviously there's a lot more staff out there who are paying for the services. So So have we got enough staff and services to do everything? We have a shortage in nursing, as I just said, definitely. We also want and need to develop more dementia care, which is why I mentioned doing something with the short centres and looking at specialist dementia care. And we absolutely need to do something the lady mentioned at the beginning in the public section around supported living, because too many people are either in their own home and struggling, where they've got physical or learning disabilities, or they're in high-end residential care and don't really need it, but could actually thrive and survive much better in supported care. So we absolutely are looking to do and build more of those kind of schemes and extra care for older people for the same reason. And we just published the commissioning plans to that extent, and that's what we're trying to focus on going forward, and we'll see that coming out in our budget as well when it's set next year.
I'll just give you a bit more context about the focus of we currently fund 488 people in a variety of care homes. There are 135 people in residential homes, 266 people in residential homes fit for people with dementia, 46 people in nursing homes, and 41 people in a nursing home that contain people with dementia. One of the challenges in placing people in care homes is that the care home needs to be able to take cash grip care that somebody requires, and frankly it needs to be in a location that the person wants to move into. So if it was your wife or your sister, you wouldn't want them moving to Daventry, because that's going to make it more difficult to visit them. So there are all those issues that we need to take into consideration. And actually care home businesses, they're not there to service the local authority. One of the things that we do find sometimes is when the hospital are what we call lack of earth, they've got no beds. What happens to the bed price? It goes up. Why? Because they know they're desperate. It sometimes seems like that. But you know, you do need to be sensitive about that, because again, if that was one of your relatives that was waiting for a heart operation or a hip replacement, would be quite nervous about it. We're not really concerned about people not picking up the, so we're trying to balance meeting a number of needs, finding people care homes that can meet their needs in the way in which they live their lives. It's not too far away, but also we do need to give people that possibility, so we don't cause any work delays.
But just one quick one, Madam Chairman, if I may just very quick sort of mention, but that's the care of the people that you're caring for in the care home.
Yeah.
You're still caring for people in their own homes.
Absolutely. Northamptonshire has the highest number of people waiting for care in their homes, and that's principally because most of our organisations So, you know, in any local paper, you will see adverts. If they get one or two people apply for those jobs, they're lucky. And what starts happening over the last 2 or 3 years is the benefits changes that have taken place. People are applying for jobs, going through the process with absolutely no intention of taking on that role. They just need to prove they've actually applied for a job. So as a sector, both Northamptonshire County Council, colleagues within the borough councils really need to work towards trying to promote care as something that people can aspire to, want to do, with some very clear opportunities for progression.
Thank you.
Councillor Hack.
Thank you, Chair. Through you, Chair. Yeah, you mentioned, well, my question relates to short PFI contract. Throughout your speech, you touched upon, said that you're trying to improve the contract. Can you elaborate on that? What do you mean by trying to improve the contract? And second, you mentioned about working with voluntary sectors. Do you intend to work with community groups or just voluntary sectors, and what engagement do you have with the voluntary sectors?
So in terms of your question, so there's 2 ways of improving the contract. One is short term, so that is making sure actually what's already in the contract works properly. Because one of the problems that we've had is we believe that sure refuse patient so it's a question of us challenging why they're saying that. And for any registered manager, any county, the ultimate right of refusal if they believe that the service is unsafe or the centre is unsafe and they take someone. So we've always got that in the background. but what we're doing is challenging them. So we're saying, they'll say, for example, this person's needs are too high and we can't take it, then we'll challenge, well, why is it too high? Because we can see from the reports, open spaces, we have the staff, we're taking the staff and the requirements of the home. So some of it is about day-to-day management challenge. So longer-term improvement in contracts is making sure that we're clear what use we want, introducing something around occupancy levels, because the contract has got no specification about occupancy levels at the moment and no penalty for them being low either. So we need to change that balance so that it's fair, we've both got incentive to keep things occupied. And then the other part is making sure that the process for referral and acceptance is clearer and there's less opportunities to refuse unreasonably.
If I could just ask quickly and then hand over to Councillor Beardworth. Going back to promoting care work and recruiting and maintaining care workers, I've just wonder whether the conditions in which people are working, especially through private or hired out companies, has any impact as well. And I knew somebody who went back to care having worked in it previously and found that they were experiencing working with colleagues who they felt were homophobic and racist, but that there wasn't the means by which they could feed that back through. This wasn't in Northamptonshire, but back through the sort of the care work, because there was a feeling that there was a business approach that wasn't really linked with sort of really looking after people, and also that the wages were quite low and the conditions were quite poor. So I'm wondering sort of how we monitor and ensure that the companies we're using or the organisations we're using do provide decent wages and decent working conditions for people, and whether there's any element in which that may affect people's desire to stay in a job, as well as people who may have unscrupulous reasons for applying.
I think that's a really good question, not an easy one to answer. So if I start with in terms of monitoring, I have a monitoring team that work to me. We have a risk assessment approach to visiting all of our providers. We want to make sure they're complying with the terms and conditions of the contract. Two, to make sure that things like their recruitment practice, their training, their workforce development is to the standard and level we expect in the contract. The other thing to recognise is that all of these services are regulated. They're regulated by the Care Quality Commission. So one of the things we do have on a monthly basis is a quality board. We also have a CQC information sharing meeting. The latter of those is where you have colleagues from health, primary care trucks, CCG, the hospitals, the county council, frankly just looking at poor services. So we do share information. I will send my team in, health will send their team in, highlight the issues that we're not happy with or that are non-compliant, and at the end of the day we come up with an improvement plan which we hold them to account. The recruitment and retention in the poor conditions is quite challenging to look at. So if we're doing the monitoring visit, we will look at their recruitment process. We will send out, or we'll ask their permission to send out staff surveys and questionnaires. Those organisations that are not treating their staff in the way which you describe will soon get found out, and frankly they'll lose their staff. There are some very good organisations out there, but there are also organisations that choose not to contract with the local authority because of the specifically high standards that we set.
Thank you. Councillor Beardworth.
Yes, mine was virtually going on the same level of performance management, really, because there's two questions: performance management of our services, to make sure that, because you always get these horrendous stories on Panorama or where people have been terribly treated, not washed, not looked after, not fed. And I know they're isolated cases, but you worry about that and how much impact is it, and the fear of that onto other people that go into care, you know, that are going to be treated like that as well. So that's one thing, and at one time I believe that the referral rate for the county council was about 2,000. Has it come down at all now? Since last, I think that's about a year ago.
You mean for safeguard?
Yes, referrals.
Well, I think we have to be a little bit careful about it. So we get 6,000 referrals a year, but just to put that into context, that's twice as many as any other council in the region. So
Why is that?
because the we have quite a challenge with partner referrals, particularly police referrals, which we're working with the police on. And there is a difference between notifying someone that someone might be vulnerable and notifying someone of a safeguarding referral. So to give you an example, and I don't say this disrespectfully to the police because it's still important we check them, and we do have to check them all. And the concern then is in checking so many that aren't relevant, because 91% of them end up in no further action. So only 9% of them actually we have to go and do something about or look into further. But to give you an example, we have had things like somebody leaving abusive messages, voice messages on a phone, and then the police reporting that as a potential safeguarding issue in terms of the person having an alcohol problem and being abusive, etc. Now that's not a safeguarding issue. So it's difficult. We're working with the police on how we get to a realistic amount, because my big fear in all of it is that I don't get to the people we need to quickly enough. Everything that comes in gets screened in the council, which is why that's a big pressure, and then everything that goes through into my services then gets rated in terms of risk, according to the level of need, whether they've got any other care or anybody else around. So we work on that constantly and update that too. So safeguarding referrals are still very high, but they're not all genuine safeguarding. I'd much be worth picking up on the performance management side of things, just a couple of things. So as a region, we do fairly well actually. So we have a really good level of good rated care homes, which is good. The CQC regularly reports on that. In our own service, our in-house services, you just naturally will get a churn of staff. So we see about 30% of our frontline staff in these sorts of services turn over in only 1 month. But it is difficult because the sad reality is you'll get paid as much to stack shelves at Tesco's as you will to go and look after someone who's vulnerable in the winter on a rainy night and things. So that is a real challenge for us. And the other thing just to say is, and even for my own services, outside of whatever Ken's team do, the monitoring team do, outside of anything the CQC do, the CQC also investigate any whistleblowing. So if somebody says, I think this person's being bullied by a member of staff, I think they're being mistreated, they do investigate them, and I really see those things checked out.
Go back to your first question about monitoring. So, as I said before, we have a risk assessment approach to monitoring. I've just had a quick look at all the care homes in Northamptonshire. That requires improvement, and that's not bad, just requires improvement. The vast majority of them are 4 outstanding services. So let's be clear that the services in general terms are not bad. However, when we do find a service that is not what we want it to be, we invite the owners and the manager in for an official contracts meeting, which I will chair. Outside of my outside, I mean the Care Quality Commission, my monitoring officers, district nurses where appropriate, and other allied health professionals will talk about the evidence they gathered for that home. We'll then allow the home or the service to explain what they're doing, why they got to where they are, and my requirements after that is for a time-limited improvement plan that looks at the issue, how they're going to deal with it, what resources they're putting in. It needs to be prioritised in terms of red, amber and green, but most importantly, from my perspective, is what the difference is for people in those services. So there is no point in saying to me, Ken, I've trained all my staff like you asked me to last time. I'm not interested. What I am interested in is what difference did that training mean to the individuals at home? Did you go and do your observation-based checking to make sure their practices changed? Did you include it in group supervision? If I look at your staff's supervision records, will I say, can I actually recognise they've had that training and their practices changed? The vast majority of services are happy to work with us and they would improve. On occasions, there will be homes that won't. Now, not to put too blunt a point on it, if you've got your commissioner from the council, your commissioner from health, and the regulator, that's very going to be in one way, and it's not well for the business. In the worst case scenario, we will remove people from care homes. If that home cannot meet their needs, and in our view people are unsafe, we will hold a meeting with relatives. Those meetings are never easy. We'll discuss what we've found. We've discussed the steps we've taken to try and work with them. But we will be upfront with people. They will get a review. We will send a team of work with individuals and their relatives. And for a lot of people, they don't want to leave. It's their home. So we will do everything we can to stop taking that final step. But at the end of the day, we don't need people in unsafe services.
But Councillor Russell, and then we'll just move through the rest of the
Thank you. Through you, Chair. Forgive maternal well-being. Does your office have anything to do with deprivation of liberty in social working?
Yeah.
Okay, because it's quite a common known fact, I'm assuming that's right, that the county council are struggling to recruit the sufficient number of adequate members of social workers. And on top of that, with the deprivation of liberty that is now becoming quite intense in some areas and needs careful assessing. I'm not saying for a minute that any of the care homes who have to apply for deprivation of liberty for their patients do not operate properly, but there's always a possibility that somebody will be kept against their will, and if they don't have a social worker to act as an advocate, that can be quite problematic for them and their family. And I'd like to know what steps you're taking for that.
So, as an authority, we have very high levels of deprivation of liberty claims, but I think, again, so unusually high, and we have lots of outstanding cases. The situation is also particularly because you have to then do a review, and it's very difficult because my own father, who's got dementia, is in a home. On some days doesn't want to be there and would be considered to be being held against as well, and other days absolutely loves it. So it's a very difficult thing, particularly with people with dementia. So we don't recruit social workers specifically for it. We have a dolls team, but we have people who are identified as best interest assessors, who are across the service, as well as external providers who come in and do that, and we also have clinical and other support, GP support. So we have a range of people who undertake these assessments, and we do them on a rolling basis. As we have so many care homes, we have a significant issue with the volume of these, and that is a real challenge. As you may know, the government's changing the rules on this, and certainly the latest advice we've had is they're probably going to change it to a self-assessment by homes, and that actually what the authority does is an accreditation. But I think it's pretty accepted in government. We didn't really intend the consequences to be that outweigh the volume that we get. To accept your point, within that there may be people who are being held against
Or inappropriately, rather than...
well, inappropriately, and in fact, we're just wide that remit to say the same about the community too, and that's a very difficult one as well. So again, go back to something that Ken just said, what we have to do is risk assess it. So we take a view on every single claim we get about circumstances, what we know about the person. If we're in any doubts, then we prioritise them, we look at those first, and then we work down to the reviews, so that the rolling reviews where somebody's unlikely to have changed really in their conditions and everything, we like the lowest priority, but are regularly done on a rolling cycle. It is a challenge, and it's always a challenge when you've got a lot of claims in your council.
Just to give you some further assurance, I met with Norwich, the Trade Association for Care Homes last week. One of the things on the agenda was deprivation of liberty and dogs, and in their view, we were far too onerous, it took far too long to come out, etc. I invited two best interest assessors to the meeting, but from their perspective, what they need to do legally, what powers the council does have, and what powers the council does not have, they sit with the court. What the two best interest assessors agreed to do is to go to the next trade association meeting of all of the care homes. I've also worked with our MTHS learning development team to put on two DOLS MCA training courses for all of our registered providers in December, and that's something that we will do on a fairly regular basis. Why? Because there's quite a high turnover of staff, and rather than get stories going around, I thought that this is what it meant. Come to the training, ask the questions, get informed, you've got a point of contact there if you're not sure. So it's about trying to build confidence and competence, and for care homes and other regulated providers to be confident in their operational understanding how it does and MCA works.
And maintain specific standards in the care of the
Absolutely.
Thank you. I think we have strayed into a number of the other points, but if there's any information that hasn't come up or other information in response to the core questions that you feel you can give us, would be really helpful, and then we'll take any questions on that after.
About the safeguarding, about funding and improvement. Just to reassure you, on recruitment, actually in adults we're not struggling the same way that children's are. I mean, the last recruitment round we did, we've got 32 candidates for qualified and unqualified support workers for social work. So, you know, I'm really hoping that it's when we can then talk and try to come to be part of the process. Just to say on the funding question, it's really important in terms of my leadership the statutory rights to think about three duties. So I have a duty to make sure the vulnerable are safeguarded and harm. The second is I have a duty to maintain the market and make sure that there's a choice in the market, which is all the challenges we've talked about. And the third one is to deliver within the resources that I've got. So whilst it's a really difficult one, and I've certainly in many committees where people will say, well, why aren't you living within budgets or why aren't you controlling it? Ultimately, if someone presents as having a need and have assessed they've got a need, they still have to provide that care. So it's a really difficult balance between those three things. The only other thing I'd probably just comment on is you asked about specific groups not accessing care. I don't think we've necessarily got a trip about not accessing care. We do have quite a lot of demand for home care. But our real challenge areas probably are, as I said earlier on, more dementia spaces as more people are getting dementia and being able to deal with more complex dementia. And the other one is really more inclusive. And we've only recently published, if you haven't seen them, the market position statements that set out the kind of care we need, in what volumes and where in the county we need it, and that's worth reading to understand that point.
Last quote for me, if I may. So from the personal perspective, I think there are lots of opportunities moving towards you, as you say. Frankly, the local authority, you don't understand that. There is a lot of understanding about the council, very good information, and making sure we jointly plan for the accommodation needs, not just old people, but people with learning disability, people with disability, they want to live somewhere. Okay, they need to live in appropriate accommodation that is planned. And our joint role is to provide services for them, potentially for the rest of their lives. People are living a lot longer, 10, 20, 30 years ago, somebody with certain types of physical and learning disabilities did was not available. These days it's not uncommon for people with learning disabilities to live to their 70s, 80s. We are about to have to accommodation for those individuals, and we look forward to working with you there, Rob.
Any other questions along those points? Okay, thank you very much. I mean, I know it's been a long session, but I think it's been really useful and it's got a lot of information there that will really help us and some good points that will help us to look at what else we need to look at and assess going forward. Thanks very much. If I can call it, Phil Harris, who is the team on it. Thank you. Oh, just before I do, did you want to access the list?
Yes.
Thank you.
I've just we've got Laura Stevens. Want the heating up as well?
Yeah,
Thank you.
Put it on a dry heat. Thank you for coming. That was really good. It was quite amazing that 18 months into a care home. That must have gone down because they're living at home longer.
Yes, exactly. They go in much more acute conditions.
Yeah. Thank you. You're welcome. What floor do you want? I'll come down with you actually because I don't want to set it off
And they're a bit
and then you get stuck on the middle floor or something.
Thank you very much. I hope my bags don't catch you.
Fine.
My bags might get in the way. Thank you.
That's fine.
Okay, thank you. It's dark now, isn't it?
It is.
More bias.
No, it's me.
I know. More bias.
No, it's me.
I know.
It's me. It should be.
It could be more bias. sensors.
You're looking at it, aren't you?
Yeah. The guy said it's on bags, I caught the bags.
Doors closing. Doors opening.
No.
Movement is slowing down.
Yes, we know that. You keep saying that. No. There you go. Right, I've got...
Doors closing.
Now it works.
Uh,
Oh, right.
I reckon I was going down the main thing.
That's it, yeah.
I think maybe I was.
Ground floor.
Thank you. Thank you.
No worries.
I'm out of a public meeting. I'm out of a public meeting, or where there is a director of adult social care for Northamptonshire County Council. Well, she didn't expect to be in that public meeting, and I just dropped some papers, bear with me. And no doubt that will get out to these public servants in my area now, because it was a further from where I was in town, with the cutback. Here I am outside the public. I'm going to turn the camera around. I don't know how to do the phone screen. So this is outside the public building. They had the meeting, and where these political representatives in Northampton, East UK, were talking about adults, all social services. Northamptonshire County Council is the one that's had all the bats for months, and I finally find out, which we didn't do, about housing and independent living and the new models. My battery's low, I've got to cut this off, and it's getting windy and cold. And you should have seen her face. Let me get down in my wheelchair. I was the only disabled lady there, and they didn't expect me to be there, and no doubt she will get to all her colleagues, because obviously she knows who I am. She took one look at me. I mean, she knows she got claiming that her dad's in a care home. So if that's the case, well, they are not offering disabled people who are struggling to get a replacement social worker in the Care Act 2014. I couldn't say anything in there because I was trying to record with respect, and it's a public building, so there's nothing unlawful about recording from my own wheelchair. And there's only me, the member of the public, there, and I was the only disabled person, individual there. So that goes to show that there's a lot of people struggling. They can't be able to get into these public meetings. This is the first time I've been here. I happen to be by this area, and I heard about it, and I happened to go. So they can't retain carers for people in their own homes because they're not being paid enough. This is nationally, United Kingdom, not just this area, by the way. And so I was asked by one of the individuals there, you heard what I said, she tried to bring that stuff that happened to me in the past, but obviously others are not there to speak for themselves, so I was picked up that point quite quick, and I said I'm not able to bring up what's happened in the past, and I was in this old system then, and now it's all changed. They're bringing in, this area is going to be the first for the UK to be 2 unity councils, so you won't have a borough council and a county council. I'm going to end this stream. It's been long, and it's been interesting to know what the plan for the future, at least. I don't know what's going to happen now. God bless.